I am presently working as Director Intervention Cardiology at Akash Healthcare Private Limited, Dwarka, New Delhi. Today I will be talking about the latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to CVD, what we call as CVDs, and cerebral vascular diseases, which affects 45% people in the age group 40 to 69. Raised blood pressure or hypertension is among the most important risk factors for CVD. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In our country, that's India, the prevalence has also gone up over 30 years to 38% in men and 32% in women. And this was earlier 29% in men and 28% in women. And this data is according to the WHO. And despite that, unfortunately, nearly half of the people with hypertension were unaware of the condition. And additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Lack of awareness is not there, and even those who are aware, they are not getting the treatment. If you look at the number of people who are getting medications for controlling blood pressure, it is only 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension, that is ISH, has released the ISH 2020 Global Hypertension Practice Guidelines. And they have included optimum and essential treatment paradigms, and this is to attempt to address the issue that is resource poor settings. Optimum care refers to evidence-based standard of care, and essential standard refers to minimum standard of care to allow specification of essential standards of care for low resource people. In 2021, American Heart Association and American College of Cardiology released a scientific statement offering new guidelines for management of stage 1 hypertension among patients with low CVDs. The concept is, with hypertension, a concept which has emerged recently in the few years is most of the patients will not be controlled by a single pill. So most of the patients will require more than one medicine, more than one drug to control the blood pressure. And instead of increasing the dose of a particular blood pressure medicine, it is advisable that we to go for what we call as an FDC, that is fixed dose combination pill. FDC is earlier in India, fixed dose combinations have been quite common. In the other parts of the world, the FDCs were not available, but nowadays FDCs have been recommended by all the societies, whether it is American or European society. So the fixed dose combination is a combination containing 2 pills. So usually what the recommendation is that patient should receive ACE inhibitors or ARBs plus calcium channel blocker. And if a patient is on these 2 medicines and the blood pressure is still not controlled, then we have to add a third medicine, and usually diuretic is added. And the target has always been that the aim is to lower the blood pressure level to the recommended, and the target is lower in diabetics and hypertension and in those with chronic kidney disease. The reason being that in diabetics and chronic kidney disease, supposedly normal blood pressure, what we say a normal level, which is maybe normal for others, it causes target organ damage in diabetics and CKD patients. So this is an important concept that we have to have a fixed dose combination. And another concept which has come is, it was realized that a lot of people have white coat hypertension. That is, in the presence of a healthcare professional, the blood pressure shoots up. And when we have a blood pressure monitoring or ambulatory blood pressure monitoring, it is found out that many of these patients do not actually have high blood pressure, but they have only white coat hypertension. Similarly, some of them have masked hypertension. That is, if you in hospital, in clinic setting, the blood pressure will not be high, but the blood pressure is high in the different period. So the concept of home blood pressure monitoring and ambulatory blood pressure monitoring, this has gained traction in recent years. And another factor, which is the reason why home blood pressure monitoring, and especially the reason for the increased use of ambulatory blood pressure monitoring, is the nighttime blood pressure measurements. So there is a realization that those patients who do not have, because normally what happens in the night, our blood pressure is supposed to decrease. But those what we call as a dipping. But those patients whose blood pressure do not dip in the night, what we call as a non-dippers, they are at increased risk of having complications to hypertension. So this is the reason that ambulatory blood pressure monitoring or home blood pressure monitoring has gained traction, and it is recommended that it should be used more frequently. And regarding the increased risk of the nighttime hypertension is, it was found out that for every 20 by 10 mm increment of blood pressure measured at night, the risk of mortality increased by 23%, and the risk of cardiovascular events by 30%, 36%. And so again, to emphasize that combination pills for hypertension are very important, and especially for adequate. And the concept is that we have to start with preferably 2-drug combination, even for stage 1 hypertension, and we have to control it early. Another factor with antihypertensive is we have seen that in few years recently, there has been a lot of concern regarding contamination of antihypertensive agents. The reason was there was a detection of a known carcinogen, namely NDMA, that is N-nitrosodimethylamine. It was found in the different sartans, that is angiotensin receptor blockers such as candesartan, irbesartan, losartan, olmesartan, and valsartan. This was classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. And the source is the active pharmaceutical ingredient sourced from China. And it was found that these drugs, that is the candesartan, irbesartan, losartan, olmesartan, and valsartan, they were contaminated with NDMA, and which is found to be a carcinogen, especially it increases the chances of having liver cancers. So this is especially a medicine which has to be taken lifelong. It is very essential that we have to be careful about it. The antihypertensive which is being given should be free of the contaminant. And another, in this context, I would like to talk about the HYDEA study. HYDEA study was the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. What they did, they tested whether nighttime therapy, in comparison to usual upon awakening hypertension therapy, exerts a favorable CV risk reduction. It was the largest study. It included about a total of 19,000 hypertensive patients. And during an average follow-up of 6.3 years, about 1,700 participants experienced the primary coronary event, and ambulatory blood pressure measurement was performed to collect data on how blood pressure differed during sleep. And what it was found out that the relative risk reduction for CV events was significantly good for nighttime treatment when compared with awakening treatment. This is an important concept because the usual practice has been that the blood pressure medicine has to be taken early in the morning, that is awakening here. But if we take the blood pressure, if the blood pressure medicine is taken in the night, then the nighttime non-dippers are benefited, and that's the CV events. And another factor about a very important factor with the hypertension is a concept which I have seen that a lot of people unfortunately have this myth that if they are okay with a pressure of 160 or 170 systolic, then they do not have to worry about it. But the fact is that any person who is comfortable, who is asymptomatic at a high blood pressure, that is, so for example, 170, 180, is definitely is used to such kind of high blood pressures, and there is what we call as there is this auto-regulation. So if a person is exposed to high blood pressures, even at 180, 200 also, he may be asymptomatic. So being asymptomatic at such high blood pressure is not a good thing. It is actually a bad thing. That means that already the damage has started occurring. So this is one myth which has to be busted. And the general, especially the general public, has to be taught about this thing that we have to be, blood pressure has to be come down, but in such situations, specifically, we have to be careful that it should not be drastically reduced because that person is used to high blood pressures. If we drastically reduce the blood pressure, then he will have symptoms of relative hypertension. And there's a very high probability that he or she may not take antihypertensive medications after that. So we have to reduce it over a period of 2 to 3 months.